All right, good morning. I would like to present this case and to seek input from my colleagues and see how best we can help this patient. So at the outset, I would like to thank my panelists, Selvi, Sylvia, Ravi, Sriram, Roy, Joseph, and Dayali. And I want to acknowledge the support of my mentor, John Stoline, Mr. Charles Butt, Ms. Angela Deal, and my institution for supporting me to do this weekly session. So if you want to get your CME, MD Anderson offers you free CME for this session. And please feel free to go to the MD Anderson site and register. And you can go to the YouTube. And if you go to my YouTube and put CME, there is a YouTube link on how to register for CME. And then you can actually click and get it from the Cloud CME. So let me take 1 second. As you guys read this, I want to apply for my CME today. And the way to do that is you go to the CME and
Selfie, do you have the web link?
251 is the page, is a text message, and then you'll get the CME registration. So Selvi and Joseph and others who have registered, hope you can get it. So coming to the case, this is a 60-year-old woman, and she had lymphoma in her late 20s, and she was treated with chemotherapy and radiotherapy. And subsequently, she had issues related to chemotherapy. You know, she had neuropathy. She also had hypothyroidism. I'm not sure whether it was related to that. And she suffers from interstitial cystitis. And she had a melanoma treated. So during colonoscopy in 2018, she was found to have 2 large lesions, one in the cecum and one in the ascending colon. And she came to see me for resection. I didn't have good pictures to figure out what I was dealing with, and it was unclear whether we could resect the lesions based on the color pictures. And I was not sure whether the cecal lesion was involving the appendix. At that time, my plan was, excuse me, to examine the colon and decide if unable to resect, tattoo the areas to define the extent of resection, and then clear the rest of the colon. By the time she came to see me, she also had an appointment with a surgeon in her own state, which is about 2.5 hours flight from Houston. And she came to see whether we can help her. The reason I put this photograph, this is my mentor, Chandu Baradan. I worked with him in Rotherham in England, Yorkshire, England. And this was a photograph that I took in San Diego. The reason I brought this picture is when I was working with him, he used to come during the weekends. And at that time in 80s and 90s, at that time, there were no electronic medical records, thick charts. And he used to pick a few charts to go through the patient's history and the course of events to understand what was happening. In the 1990s, in the 80s and 90s, he was doing a lot of work on peptic ulcer, and he has made a lot of contributions to the medical management of peptic ulcer. So when I was going through this case, it reminded me of my observations, watching him come to the office and go through charts and learn, I think, from the cases themselves. So coming to back to the procedure, this was the first procedure. It took about an hour and a half. And as you can see on the right side, two large lesions in the cecum and ascending colon, and we were unclear whether we could resect. And I put this diagram to give you a little bit of a better feel for how I did this case. So I came to the cecum, I identified one large cecal lesion, and then there was another lesion opposite the ileocecal valve. The lesion that they described as ascending colon lesion, I could not identify, So I said to myself, what is happening? Let's examine the rest of the colon. And I examined from the cecum to the rectal rectum. And then I found another lesion, as you can see here, in the transverse colon, closer to the hepatic flexure. And then another lesion, again, big lesion in the descending colon at 30 millimeters. So I placed tattoos. Tattoos were placed to that site, hoping that I would come back and resect this after resecting the cecal lesion. So I came back to the cecum and we performed an EMR. So this is what the pictures are. As you can see, this is a right side appendix, and the cecal lesion is very subtle. It's a flat lesion, just very, very subtle. And then with NBI, you can see some changes here. And there's another lesion in the opposite ileocecal valve. And here is the transverse colon lesion. We placed a tattoo. And then descending colon lesion, and we placed a tattoo. And then the rest of the colon looks okay. So coming back to the cecum, I used NBI to define the boundaries of the lesion, and then we lifted the lesion. And as you can see, we did a piecemeal EMR, and the margins were clear. And then we applied APC, and then we closed the defect. All right. So that pathology came back as tubular villus adenoma, no high-grade dysplasia. I'm going to go a little bit to the next procedure. So we brought her back, a second procedure. This one took, again, close to 2 hours. And as you can see here, as I'm going up in the descending colon, the lesion was seen 30 millimeter lesion. We did the EMR, and another 5 millimeter lesion we did in EMR. And then we came down to the cecum. The cecal EMR site was identified, but I was surprised to see something else. So coming back to the pictures, descending colon, again, a large flat lesion. We did a piecemeal EMR, and the resection looks good. We did APC, we closed it with clips, and then we came to the cecum on the right lower corner. And then the cecal scar shows still clips. And then here, I was a little bit baffled to see this large lesion occupying the entire cecum. And I used a little bit of chroma endoscopy, and I could not define the boundaries of the cecal lesion. So I requested one of my colleagues, Pat Lynch, to come and look at it. And he was surprised. And then he said, this is not something we could resect. So we came back and to the so-called hepatic flexure proximal transverse colon lesion, put an additional tattoo, and then resected the descending colon lesion and came out. So the goal was at this time to have a right hemicolectomy with the inclusion of the so-called proximal transverse colon / hepatic flexure lesion included. all the specimens came back as tubular adenomas, whatever we dissected. Underwent right hemicolectomy and came back for a third procedure, MD Anderson. Here is end-to-side ileocolonic anastomosis. And then a few centimeters downstream, we can see this lesion here. Again, very subtle. We did MBI, we defined the borders. And as you can see, we resected and then we closed the defect and we examined the rest of the colon. At that time, we didn't see anything, right? So again, pathology came back as tubular adenomas. At this time, given the subtlety of the polyps and the fact that she had a chemoradiation and she had a melanoma, and there's a family history of breast cancer in the sister and mother, we asked for a genetic testing. And all these tests came back negative. So at this point, I wanted to just wait and maybe ask, we have two people, Sylvia and Selby, who have a lot of expertise in high-risk cancers. And I want their input into this case. What are your thoughts?
Well, it's a very interesting case. Thank you for sharing this very, very interesting case. I think in my opinion, she had multiple lesions, multiple polyps, but I'm not sure she would meet the criteria for a polyposis syndrome to test from our approach. I mean, I see that you have testing also for muti-H, for POL and POLD. It's a lot of genetic work has been done in this case, but I'm not sure that I would have tested this with this information. And the family history is actually also not conclusive. Two first-degree relatives with breast cancer will point towards more to BRCA mutations instead of a hereditary colorectal cancer syndrome, I think. To summarize, lady in her 60s with lymphoma and melanoma in her past history and multiple, but I think not less than 10 large flat lesions and recurrent lesions during the follow-up. Am I right?
Yeah.
So I think at this point, I would not do additional genetic examination, and I would continue to do follow-up with chromoendoscopy, as she had multiple flat lesions. And I think that is the key point at this moment for me, to rule out additional flat lesions in the follow-up.
Right. Okay. That's good. Let me ask Selby what her thoughts are.
Thank you, Raju. Sylvia, I think, summarized it beautifully. This is a lady with multiple tubular adenomas, no other types of polyps that have been removed. So I'll talk a little bit about our process in the clinical cancer genetics program at MD Anderson. If a patient has more than 10 adenomas in any single exam, or more than 20 adenomas cumulatively total over the course of multiple procedures, that's generally when we start thinking about a colon polyposis type syndrome. Although we'll see patients who are referred to us regardless of whether they've met the threshold or not. Just looking at the list of genes that were tested, it looks like it's a colon polyposis panel, colon cancer, colon polyp panel. And none of those came back with a mutation. And I agree, Given the fact that she has family members with breast cancer, it would make sense to include BRCA1, BRCA2, and those types of genes in the panel. And it doesn't, I'm not sure if they weren't checked or if they were negative. Anyway, those are my thoughts.
All right. So 1 second, I'm actually trying to send a link to Dayali. So
Do you want me to do that?
Yeah, you want to do that? You have her.
I have her MD Anderson email.
Yeah. One second, just bear with me. Why don't I just play this video? And I don't know whether who else is here. Okay, as I see Zubair. I want Zubair to comment on this. I think it's a good idea for him to. All right. All right, Zubair. Are you there, Zubair?
Yes, sir.
What do you see?
So I see a large flat lesion, which is like extending, like maybe crossing a couple of folds. I'm not able to like exactly define the borders, but it looks like to be a large flat lesion, which is and crossing the folds.
Okay. See that? All right. So let me show you MBI. And it's actually interesting to give you a little bit of perspective. We ran late that day. And by the time I started this procedure, it was 5:30 in the evening. And when you see a lesion like this at 5:30 in the evening, after having started your work at about 7 o'clock in the morning, you wonder what's going on in your mind, right? All right. So we saw this large lesion, and one thing is when you see a large lesion, is I think Roy would say, why not put some chromoendoscopy? That is, I think, would have been a good idea. But what we did was we decided that, okay, we're going to resect. And I didn't want to just resect without defining the border. So we used an APC to define the border. As you can see, it is so subtle. And we used a PD scope. I wish I used an adult scope. Because of our previous surgeries, I felt that a PD would be easier to do. But if you have an adult scope and you have a near focus, you can define the transition much better. But you can see the transition, right? On the left side is normal. On the right side, there is a little bit of granular appearance.
It's an SSA, no?
Say it again.
It's an
It is
SSA.
an SSA.
Yeah. Yeah.
Looks very much like an SSA.
It has a positive O signs.
All right. So we set it up with 15 watts forced APC. And as you can see, we decided to define the border. For the sake of time, I just edited it so that you can see the extent of the lesion. So when you're defining a border, it's always best to go on the left side and come from the cecum to the rectum, and on the right side from the cecum to the rectum, rather than going clockwise 360 degrees. It's much easier to do that.
It's a big SSA.
It's
Yes.
a big lesion, yes.
Yeah. So one thing is the difference between Roy and Sylvia is Roy committed, Sylvia did not commit yet.
It's 100%.
Okay.
I still have my my doubts, and I would like to ask a question if possible.
Please.
Of course, the genetic tests could not confirm a polyposis syndrome, but as we know, only 1/3 of the patients with suspicion of polyposis end up with a positive genetic test like positive muta-H gene mutation, biallelic muta-H, or APC, or POL or POLT. So we can't rule out 100% the polyposis. And I was wondering whether the patient also got an EGD and small bowel evaluation.
So no, we haven't done that
Not yet.
yet. I wanted
Not
to, I wish, that's why I wanted to present the case to get input. We are going to look at it. So I wanted to
Yeah.
share with you here for
Hold
the
on,
sake of,
Raju.
Yeah.
The first lesion in the cecum that was resected many years ago
Mhm.
was an SSA.
No,
This
Villa
is-
said no.
Tubular.
Yeah, but they made a mistake. You can go back.
Huh.
Endoscopically, it was an SSA. I can tell you that.
Okay, all right,
So can you try that to go back and then let us know?
all right. We'll
An,
look at-
an SSA with dysplasia, you mean, Roy? SSA,
No, I don't see the TSA that they're talking about.
it
Can
can't
we-
be a TSA, but I think that's.
Can we look at the images again? Because I agree with Roy that the image which you first shared looked very much like an SSA with ill-defined borders, cloud-like appearance.
That's
Maybe because it's multiple polyps resected in piecemeal, and since they were all close together, there's a possibility that the samples might be mixed up. If
So this one is an SSA. You see, because it turns white when you after you inject. It has so many O signs here. This they call this adenoma again.
I'm not going to tell you anything.
you make it even more challenging for us.
This is an SSA until proven otherwise. And if somebody calls this an adenoma, I would say I need a second pathologist.
I agree that endoscopically it's very likely to be an SSA.
All right, Sylvie, make sure that Dial comes on the screen, okay?
I sent her the link already, Raju.
Thank you so much. Really appreciate it.
I'm here.
And
Thank you, Dayali. Don't tell them anything yet.
when there
Yeah.
are many SSAs, the SSA don't have a genetic disease. So all of this testing is not very useful.
So it's interesting that you say that, Roy, because I think it's important, just like we try to keep track, or we should keep track of how many adenomas, conventional adenomas a patient has. It's also important to keep track of how many sessile serrated adenomas a patient has, and to be aware of the WHO classification for a serrated polyposis syndrome. And only by keeping track of the number and type of polyps are we able to see who meets criteria for that. In terms of genetic testing, for that, one of the genes that we include is the RNF53 gene. And there's most of the time, again, just as Sylvia said, we don't find that the patient has a mutation in that gene, but I don't remember seeing that in the list of genes that were tested. Generally, once patients meet serrated polyposis syndrome criteria, then they should have exams done every 1 to 2 years by an expert endoscopist who's good at picking up small SSAs.
And this would be the same if the patient would have an muta-H associated polyposis or an attenuated FAP. So in fact, the endoscopic follow-up is almost the same.
Agreed.
All right. So one thing I wanted to share with you is a couple of things. I want to make a couple of comments for the sake of the fellows here. especially Zubair and others. So what happened was initially when we started, we set her up for EMR. And I think you can see in my first video, I picked up a larger snare and I struggled with that. I picked up a 15 millimeter snare, hoping that, okay, I could cut a little bit faster with a 15 millimeter. And this lesion doesn't, looks relatively easy to cut. But what happened was, as I used a 15 millimeter hard snare, whenever the assistant tried to close, the assistant who helped me is very experienced, so one of the best in our group. And he kept cold cutting that. And the cold cut was with the hard snare, the Olympus hard snare, Snare Master. The cut was getting a little bit superficial, and the polyp was slipping through that. So then I decided that I'm using a hot snare, but I'm ending up cutting cold. So at that point, I said, why don't we just shift to the Snare Master plus cold snare, the hot and cold snare, and then decide to do this resection as a cold EMR. You could see this with this change in the snare from a hot to a cold. My cuts were a little bit better, and I was able to control and resect at a much faster pace. And I'm able to bring my snare underneath the polyp, as you can see here, and cut the polyp. I have not added any epinephrine into the solution. People do describe adding epinephrine when you're doing a large cold snare resection to cut down the risk of bleeding. And in this case, we did not add any epinephrine. It's just a saline and a little bit of methylene blue. I felt that, you know, this cold snare is able to go underneath the mucosa and give me a better cut than with the hard snare. As you can see here, this cut was just cutting through that muscularis mucosa there, and the submucosal vessels tend to pop through that muscularis mucosa. You can see that, right, Zubair? So you just saw that small strip of muscle there, and then through the muscle, there was a vascular bundle. You can see here, right? A vascular bundle come up through that. So we continued the cut. Basically, you need a little bit of patience and do overlapping cuts and take time to inject and make sure that you have a good injection. Roy has nicely demonstrated last week about the use of dynamic injection technique. So it's the same thing. You know, if you know how to inject, you can cut the polyp. And one thing is, you know, notice this, the stiff snare allows you to put your snare deep into the tissue and cut it. And the second one is the stiff snare will allow you to anchor on one side and flip it to the other side and then cut it. So something to just keep in mind, you know, when you're using a particular instrument, you need to know how that instrument is going to work for that particular cut. As you can see here, we are anchoring there and then going underneath and then trying to get the polyp without leaving too much of bridges. You know, if you leave too much of bridges, it becomes harder. So you need to have that patience to get it underneath the edge and then reset, as you can see here. Sriram, any comments? Roy?
Yeah,
Beautiful case, sir.
I send the materials to the participants on the image enhanced endoscopy of IEE, of SSA.
Okay.
For this kind of piecemeals of less than 10 millimeter pieces that you're taking, there are two other snares, just for the sake of completion of discussion, for people to know that one of them is a monofilament snare from the US endoscopy. Now I think it is taken over by Steris, and that is one good snare. And another one is a 10 millimeter cold snare from Boston Scientific. That is a little more stiffer. So both have that kind of a ability to anchor and avoid that slippage that you were talking about when you're using the other snare. And just for people to know what other options are available.
Yeah, thank you. So it's actually, I think, the most important thing for the sake of fellows, especially Zubair, is when you, as you can see, we are trying to get underneath the edge before we resect, and you need to have a little bit of patience to make sure that you get underneath the edge so that to cut it right, so that you don't leave too much of islands. You know, if you leave too much of islands, at the end of the day, you have to sit there and then try to remove those islands, which is not going to be difficult, but I think it will add to your procedure time. So keep in mind to be able to do that resection properly. And to be honest with you, there's not much to the technique of it. You know, just have to inject well and then cut it right. So this is the almost towards the end. Basically, what we did was, I want to share with you. We thought that we were done. I think we started around 5:30. We were cutting till about 7:30, and then at the end of the procedure, when I think I'm done, I usually go around the edge, millimeter by millimeter, to document that I have achieved complete resection. And if in case you know that you didn't, and then we realized that on the northwest corner of the resection, we left almost a 2 centimeter area that we did not resect completely. And then I'm glad that we did that. Otherwise, the polyp recurrence would be much, risk of polyp recurrence is very high. So we went back and defined that area and then resected it. And then we put a tattoo here. And then we pull the pieces. And why don't I do one thing? If I could go to a couple of, I'm going to summarize, and then I'll ask Dayali to show the pathology slides. So here is the transverse polyp. Roy, do you say it is 2B or 2A?
This could be a 2B.
Okay. All right. So while I'm doing this, I want Zubair to tell us what is 2A, 2B, 2C. So we injected about 45 ml. We used the following snares. Initially, we used endocut, but it was mostly cold snare. The patient had to fly back to her home state, about 2 hours flight. I was a little bit worried, you know, how she would do. I called her several days following the procedure every day to make sure that she did well. And I think by God's grace, she has done well without any complications. So let me sign off from here and let Dayali share that screen.
Okay. So you can see my screen, right?
Yeah.
Okay, I just wanted to start with an overview of the basic polyps that we see so that, you know, it's easier to explain the histologic findings in this particular polyp. So the top portion shows basically a lot of serration in the glands. So these are serrated polyps. When the serrations are more in the superficial area, but the glands in the deeper, which touches the muscularis mucosae, look normal, that's what we call hyperplastic polyp. Whereas here, now this is a case that I showed before of our sessile serrated lesion, where the serration is reaching down to the muscularis mucosae. So this would be a sessile serrated lesion. And so these are sessile lesions in general, but then, so this is basically a very subtle difference between hyperplastic polyp and sessile serrated lesion. Now the bottom polyps are showing more darker glands than surrounding normal. So that dark is what we call cytologic dysplasia, or like the conventional dysplasia. And the morphology, when it has, you know, a lot of villiform processes, is the villus or tubulovillus. And then when it's more glandular and the surface is more or less rounded, that's a tubular. So this is a tubular adenoma. This is a tubulovillus adenoma. This is, and these have stalks. So they are, you know, in that sense, you can resect the base, which is like, you know, basically with stalk, and then this one is more sessile. So this is how normally, you know, this is what we see in regular day-to-day polyps. Now coming to the polyp that was resected, this one, the subtle polyp in the cecum, we had a lot of mucosa to look at, and most of it, you know, had, so the problem with pathology is like all these pieces may not all have good orientation, but a lot of this areas like are well oriented, because we see this is the muscularis mucosae here down, and then the top is the luminal surface. So some of these pieces are well oriented, some of them are tangential. But so we had a lot of mucosa to look at, not a polyp that's, you know, jumping on your eyes, but what is happening is some of these areas are abnormal, and I'll show you in higher magnification, or this area. But what we are seeing in low power is like there's not much thickening of the mucosa. So the thickness is more or less that of normal. Here is a higher magnification where the thickness of the mucosa is more or less normal, but we see these glands at the superficial, you know, at the surface that are showing some dysplasia, cytologic. And this dysplasia will be classified as tubular adenoma. Now, regarding other areas, some of the areas did have prominent serration. And so when you see serration, you would think of a serrated polyp, of course, but there is also cytologic dysplasia. So question may arise that this is cytologic dysplasia arising in an underlying sessile serrated lesion. However, we did not see any areas that resemble a non-dysplastic sessile serrated lesion. So if we don't see that, the lesion will be lumped into tubular adenoma. Although I agree that this polyp looks different from what the polyps usually histologically present. So going back to the first, you know, even if it is sessile, it's usually a little raised. That's what tubular adenoma would normally be. Here it's sessile. It's the polyp is not raised. But the cytologic dysplasia is essentially present in all these abnormal fragments. So there is no mucosa that is showing features only that are serrated without cytologic dysplasia. So there is no way that we can place this polyp into a sessile serrated lesion. Any questions?
I respectfully disagree. I think your last slide showed some SSAs. This is, I happen to fairly know a little bit about pathology of the colon. And if you look at this one, there are a lot of goblet cells. And usually we don't, at least in 2021, we don't think that there is a collision polyp anymore. whereby SSA collides or hyperplastic collides with an adenoma. So the way we think about this is that this thing arises from an SSA that changes into an adenoma. On slide number 3, your cut, and you're in here not meaning you, but the cut is really not correct. The cut is parallel to the surface, yet you still see a lot of goblet cells, which is not typical for an adenoma. And a way back ago, we actually published a randomized trial that tells you that if you want to make a diagnosis of SSA properly, you need to orient it. And when you don't orient it, such as in this case, then your yield of diagnosing an SSA is really, really poor. And we actually, I have included the paper on that, and it's very easy to do to make a diagnosis of SSA if you use this method of orienting. So I think the problem is not the pathology or the pathologist here, but the problem is that the preparation of the specimen was not done correctly. So when you cut it the wrong way, this is like all poorly prepared specimen, then you do not see what you needed to see. You tend to make this diagnosis that either indeterminate or makes the pathologist confused. And just like what you just said, we actually don't have the good, properly tangentially cut specimen that we can make the diagnosis. But please take a look at the last paper that I put in the chat. Try to follow the way it should be done. It's really simple. You just require some papers to do this, and you put your specimen on this piece of paper. The paper will absorb the water from the specimen and then will make it oriented. And then you send it to the pathologist, and the wali will say, aha, this is very simple. This is an SSA. When you cut it like this, it is so difficult.
Thank you for your comments. The thing is, that orientation problem is really hard to when you have to distinguish between hyperplastic polyp and cis-ulcerated lesion. However, orientation is, first of all, as you can see in the lower magnification, a lot of these pieces are still well oriented. All these bigger pieces that are very beautifully oriented, and we can say this is the luminal surface and this is where the muscularis mucosae on the inner surface is. Here too, the muscularis mucosae is in fact quite thick here, and the orientation is in fact, a lot of these pieces are well oriented. That's number one. The problem is if it is not well oriented and if it is tangential and you just see serrated glands and you don't know where the luminal surface or the basal surface is, it's definitely hard to classify that polyp into hyperplastic or cis-ulcerated lesion. However, when you see cytologic dysplasia, that's not allowed for a cis-ulcerated lesion unless you see a cis-ulcerated lesion without cytologic dysplasia and then adjacent to it where it develops the dysplasia. In this case, I did look very carefully as the morphology of this polyp is unusual, and I did try to find other areas of serration like this, however, without dysplasia, and that was not present. So maybe, I mean, this is an unusual polyp and probably it arose in that background, but essentially now all of that lesional tissue shows cytologic dysplasia. So when you see cytologic dysplasia, this is not about orientation, then it would either fall into a conventional tubular adenoma, or it would be a cytologic dysplasia in a cis-ulcerated lesion, but we don't see a non-dysplastic cis-ulcerated lesion in this case.
Diwali, if Raju had done an ESD on this polyp, you would have seen the transition point between the SSA into an adenoma. But because he cut it into piecemeal, then you have these pieces that are adenoma and then pieces that are SSAs. So if you say piece 2 and 3 are adenoma and piece number 4 is an SSA, and they come from the same polyp, you need to believe that they are a continuum, that they
I agree with
represent a
you, but
continuum.
I had there was no
hold
fragment.
on. So when you have a continuum, that would be an SSA with dysplasia. In this case, there is no malignant transformation, but this is an SSA with dysplasia that will need perhaps a close follow-up, especially because it was a large one. I think this patient may actually have an SSP, cell-saturated polyposis, if you look back at all of the pathology. Endoscopically, there is no question whatsoever that what Raju has shown over the years, especially the first one, was actually an SSA. I think, you might want to look at it and say, in the prior specimen, were there any SSAs in the components that you call as tubulophilus? The first lesion that he showed, there is no way on earth I would call it as a tubulophilus. That was an SSA with a cloud-like appearance of an SSA.
May I ask a question to the pathologist?
Yes.
Thank you so much for sharing these beautiful slides. My question is, what would be your clinical diagnosis corresponding to these pathology findings? In the end, we would like to know what the patient has most likely in order to determine the best surveillance interval. So what would be the clinical diagnosis of this case, in your opinion?
I mean, I think based on the pathologic criteria that we had, there is no other diagnosis but to call it tubular adenoma, however unusual it looks like.
Mm-hmm. So you would suggest an adenomatous polyposis syndrome, am I right?
Yes, but this is the only specimen that I've looked at. It would be great to have reviewed the resection,
Right.
because the resection would have some lesion, but then adjacent to look at, and the orientation would be the best. So I mean, I'm a little uncomfortable just labeling it as such based on this specimen, but this specimen definitely, I mean, it's very unusual, but there were no fragments that had non-dysplastic areas of SSA, therefore I couldn't place it into SSA. Although, I mean, I definitely showed you areas that made me think of the possibility of SSA.
Just to put my question in a bigger picture, it is relevant for us as clinicians to differentiate between a serrated polyposis syndrome and an adenomatous, because the serrated polyposis is never associated with upper GI pathology. It is very unlikely. So this patient would not need an EGD and a small bowel investigation like video capsule and double balloon, which are invasive. The double balloon is invasive. So we would not like to do that if it's not necessary. If we are talking about an adenomatous polyposis syndrome, like an attenuated FAP, a muta-H, which she doesn't have, but just to explain you my question, then we should do an EGD and a small bowel investigation. So this is the consequence of my question for the patient, I mean.
Yeah. So let me first, Sylvia, thank you so much. What actually I want to thank Dayali for bringing in the slides, and she didn't have an opportunity to dig through the previous slides, and maybe I'll request her, we can actually go back and look at her original resection that was done in 2018 to see whether it was a tubular villus adenoma or whether there's an serrated polyp. I think that would help us. We will do that. All right. Tayali, thank you so much. It's a very, very tough case.
Much.
That's the reason I've actually brought it, so that people could help us figure out, how to help this patient. Because at the end of the day, we have with us some of the best minds in the world. So we will look at the previous slides also. And I wanted to ask, what would you tell this patient? Let me ask each one of you, Roy, Selvi, Sylvia, Sriram, Ravi, Joseph, Dr. Graham, and Dr. Stoline. What would you tell this patient? And this is one thing that happened. And I finished the procedure around 7 o'clock, 8 o'clock. And then when I went to discharge the patient, I ended up sitting with her for another hour till about 9 o'clock. Because she was a little bit disappointed to have this lesion found, and kept asking, why the heck am I forming these polyps? And you have all the information so far. And what would you tell her? And are there anything that you would do in addition to surveillance at 6 months to a year? Because I didn't examine the remaining colon. I recommended that she should have the next exam in the next 3 to 6 months, and consider doing the maybe chroma endoscopy. And one problem is because of the COVID, she needs to make another trip, get COVID tested, stay there for 2 days. And because of that, we're wondering whether she could have care locally. So let me ask you, what are your thoughts? What would you tell her, and what chemo prevention? If there is anything.
I think if I was the person resecting it, I would say, under no circumstances could you be flying back. There is perhaps some impacts of flying and changes in the pressure and all of that. And having a 5 centimeter resection and then hopping into a plane is not a good idea in my mind. If it was to bleed, it could be dangerous. And she should be thankful that it could have been resected by endoscopy, and may need some take and give there. The other thing is that because the lesions that she has is like a SSA of 2B type, they are notoriously very difficult to find. And I would actually perform a chromoendoscopy using indigo carmine next time, specifically looking for completely flush to the wall lesions, the 2B serrated. I would use a cap and look carefully because I think she probably has more, and there's also a possibility of a residual at the resection site. Lastly, I would like re-review all of the pathology samples that have been done to determine whether she has an cell-serrated polyposis or not. Because if she does, her follow-up will be very different. She will need a screening surveillance colonoscopy every year, forever.
All right, thank you.
Number 4, I've included many links. The last link is like how we use endoscopy, endoscopic enhanced endoscopy to detect, especially for SSA and diagnose SSA.
All right. Sriram.
Yes, sir. Beautiful case, and I can't think of anything different. But one idea I have is that because all the polyps are all the time, these are flat polyps requiring multiple injections and resection. It may be for the proceduralist, it may become easier to use a snare with a combination of injection and snare, so that
You don't have to change instruments too often. So there are a couple of those snares are available out there. The second is that, of course, I agree. She will, no matter what, she will end up with a yearly colonoscopy. So I might, it's off the book. I might venture that I repeat these colonoscopies once a year, and rather than again bringing her back in 6 months, even if there is a residual adenoma, sky won't fall. She has been through quite a bit, and she will continue to require these things in future. So, and under one person who does these procedures all the time, even if she comes back after a year, I try to convince her that way.
Okay. So let me ask you this thing. That one of the reasons I was put off with this injection comes Snare combination. Although I like that concept, it is harder to push through a pediatric colonoscope. Yeah, are the current snares smaller now that are easy to do now?
There is one. I agree that way, because the bulk has to be bigger than for just a snare. It will compromise the lumen. But I've used with both pediatric and adult scopes, as well as the therapeutic gastroscope. But the advantages versus the issue of suction that you need during the procedure. That's the balance.
Right. All right. Selvi?
Yes, Raju, a very interesting case. It generated a lot of discussion, especially thanks to Dayali for preparing the slides and giving such a beautiful description. It's always nice to look at pathology images. I enjoy it. So in terms of, and I agree with everything that's been said so far. I agree with what Roy said. We had talked earlier, I made some comments about serrated polyposis syndrome. So I think, if the patient is concerned enough about a genetic cause, I would tell her that the majority of the time when we do a genetics evaluation, we don't find a cause, a particular gene that's mutated that would be the culprit for the polyposis syndrome. If she's highly motivated, we could of course check for the RNF43 gene, but again, in the majority of cases, those are negative and the patient still have polyps. And I would just reassure her that it's multifactorial in terms of why patients form polyps. And the best thing that they can do is be proactive, as she has been, about getting yearly colonoscopy done. I'm not sure I would be nervous personally if she was my patient for her to get colonoscopy done locally, unless it's somebody who's very good at detecting serrated polyps. And then also they're working with an expert GI pathologist like Dr. Chatterjee that we have at MD Anderson, who's going to be able to call the polyps correctly. Those are my comments. Thank you.
I think I should comment on your equipment. The equipment that was used, the pediatric colonoscope, probably does not or did not have the right optics to give you the high confidence to make the diagnosis of SSAs or to use the NICE classifications. And we have shown that in a randomized trial before. So you will need really something that has a near focus. And back in 2015 and 16, and Ravi was there, we actually gave in our specification, and it was designed, it was tested in Singapore, of the proper colonoscope to be doing this, which is a pediatric with a near focus. And now it is available worldwide. And I strongly suggest that if you were to use optical diagnosis and with that proper IEE, I would suggest that you use a near focus capable pediatric colonoscope. Otherwise, you will have this feeling, oh, I see it, but maybe I'm not so sure because you're not so highly confident with the diagnosis.
So Roy, do you have near focus capable pediatric scope in your place?
Yeah, I do. I actually in my private practice setting, I sometimes see this SSA that's completely flat, and I insist that the facility provide me with the pediatric near focus. And the reason is that when you have a petite size patient, and that could be especially the younger women patient, then doing it using the adult colonoscope will not be conducive. The patient will be very uncomfortable, and you actually will also be uncomfortable because you are so concerned whether you're going to perforate or not. And then the whole exam then becomes not very, very useful. But you need to have the right colonoscope. I'm not getting any royalty from what we had contributed in the field on that. But when you have the right colonoscope, then you can do it with the comfort of the patient and your comfort, and then you can make the right endoscopic diagnosis.
So,
You're the kind of thought leaders who should push for these things. Like in this day and age, with the screening colonoscopies being done so many, and there will be some more, many more, and with flat lesions being identified more and more, I see no reason why every colonoscope should not have these capabilities of near focus, and you should push for these things. They won't listen for anybody, the lesser mortals.
so let me ask.
We named the colonoscope as the universal colonoscope, and my understanding is actually the most colonoscope, most type being sold today.
So I didn't realize that when we first talked about it, when we bought our own Olympus system, at that time the near focus was not available. Did you get these scopes recently, or have they been available for a long time? And I want to ask Laura, one of our chief technicians at MD Anderson, to comment on and whether we can get those things also.
So the universal colonoscope became available in this country, I think within the last maybe 12 months or 16 months. It's relatively recent.
And what is it called? Is it like an?
I'll text you.
Okay. Laura?
And in this patient with a right hemicolectomy, probably you can get away with using a therapeutic gastroscope.
If you use a therapeutic gastroscope, you have the high definition capability, but again, you do not have the near focus capability. And then you may feel that, oh no, is my diagnosis correct or not?
Laura?
May I have a short, quick comment?
Yeah, please.
Go ahead. Yes.
So I think that a practical issue, I think I fully agree with a yearly follow-up colonoscopy in the future, but at the first examination, which will be probably in 6 months, given the piecemeal resection of the last lesion, I think it would be worthwhile to evaluate once the upper GI tract. And why? Because even if it's a serrated polyposis syndrome, we know there are so-called mixed polyposis syndromes, which combine the phenotype of the serrated polyposis with a multi-age associated polyposis. I don't know. So I think it will not be, it would be a good decision to examine the upper GI tract once at the first examination. If there are no lesions, no follow-up would be indicated. And regarding the last question, whether chemoprevention should be tried in this case, I would not try as long as I don't have a diagnosis. And if it's not an adenomatous polyposis syndrome and not a FAP, actually the only data what we have for successful chemoprevention are in patients with familial adenomatous polyposis. So I don't think there is a place for chemoprevention in this case.
Thank you so much, Sylvia. Laura?
Good morning.
Go ahead.
Can you? Yeah.
Yeah.
So, our scopes, we just recently, I mean, our scopes are over a year. I think we got our new scopes like almost a little bit over a year. So of course, we were not aware that they didn't have like the near focus on the PD colonoscopes. But I will reach out to Joe Hearn from Olympus. So maybe we can probably, discuss with Denise, see what we can do about it. We can probably at least maybe get one or two.
Yeah, I think that's a good idea. I think it's good. I didn't realize that. I was under the impression that PD scopes are not designed to have a near focus. So.
Yeah, me too. I was on the impression that they will have like the near focus, but I guess they are not.
All right.
But I will definitely reach out. We'll definitely discuss this with Denise tomorrow morning, and then I will reach out to Joe and I will keep you updated.
Thank you so much. I'm glad that you joined. We appreciate the value of having the right scope given the particular patient. I really appreciate it.
Totally agree. Yes. No, thank you, Dr. Raju.
So let me ask Dr. Graham if he has any comments. And Dr. Stroline.
It's always interesting to see that how important it is to have the right tools.
Right. Thank you, sir. Thank you. Roy, do you want to do that other one or you want to push it to the next week?